Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Doug. How are you doing today?
I'm great. Happy Sunday morning to you, Dennis.
Happy Sunday morning. So in kind of a continuation of our cardiac arrhythmias, something that at least my side of pre-hospital medicine rarely practices anything about it. I'd like to talk about bradyarrhythmias, and I couldn't think of anybody better than you.
Well, thanks.
You haven't heard any of my questions yet. So
I have not heard any of your questions. I'm not going to even anticipate.
It's generally best to not worry about it until it happens. So first off, I think just starting off, like, how on earth would you recognize somebody's, symptomatically bradycardic other than their pulse is low?
That's how you recognize it, and as part of your primary assessment, you should be checking vitals. And if you check vitals and their heart rate is 20, you've got a problem.
Yep, that checks out. But not, I know, like, American Heart Association says, 50 or less. But you also have people that are kind of running hot on the daily. If it was, their heart rate was, 60, but they're symptomatic, would you still treat them like bradycardia?
Probably not. It's probably something else. Usually a heart rate is sinus 40s, 50s, 60s is going to be a perfusing rate. I'm sure there's somebody out there who would be like, well, I had this case when I was whatever. And so, but in general, we don't get that concerned. It's hard for me to get a cardiologist concerned about putting a temporary pacemaker in somebody whose heart rate is sinus in the 60s.
All right. Too easy?
It's usually pretty low. And then the other thing too is not all, but many / most unstable bradycardias are caused by something called complete heart block or third degree heart block, which is, you can see on a monitor. You don't need an EKG to do it, although an EKG is a bit more precise and defined. But basically you have P waves that are completely dissociated from your QRS complexes. So your heart rate is going to be your QRS complexes, right? And that'll be, in these cases, 20, 30, 20s, 30s. But then you'll look at your P waves and they'll be like 60s, 70s, maybe even more, right? So it's the block is that you're not getting conduction from, you're not getting transmission of your atrial impulses to your ventricular impulses, right? So you've got the P waves are your atrial impulses. You're getting a lot of those, and then they're getting blocked at the atrioventricular node and only incompletely transmitted, and so that maybe only a third of them get through or a quarter. So other than just heart rate, what other signs of shock are they going to show? Obviously, like altered mental status would be one. I'm guessing just poor signs of perfusion, like real pale skin, diaphoretic maybe. Yep, exactly. A lot of these cases come in because somebody fell, or got up or felt like they were going to fall, like super lightheaded. And you can be in frank, hypotension, hypotensive shock. Your blood pressure can be low. But yeah, the clinical signs, lightheadedness, actually falling due to lightheadedness, diaphoresis, sweaty, cool, clammy, sweaty. Yeah, 100%. Very, very typical signs of cardiogenic shock, of which this is a form of cardiogenic shock.
Like, what about causes? So, I'm come upon or I'm called to somebody who fell, somebody's not feeling right, etc. Like, how do you go through your differentials that early?
Right. Well, so for the EMS crowd in our audience, we will see the general population of all ages. Probably the number one cause of unstable bradycardia and complete heart block is just age and the electrical conducting system getting worn out, and that happens. And the heart is composed of four components, any one of which can wear out, any one of which could send you into cardiogenic shock when it does wear out. And the conducting system is one, the valves, the muscle, and the blood vessels, the arteries being the other three. So that's the most common cause. For the military in our audience, there are very rare forms of AV conduction abnormalities, Brugada syndrome, Wolff-Parkinson-White. I'm not even going to go down those rabbit holes. But most commonly, actually, it's going to be Lyme disease. So probably not going to see that too much in a I did some reading for this podcast like I usually do, but I actually didn't look at the incidence of Lyme disease overseas. But, ticks, Lyme endemic area, it could be, in the forests of Northern and Eastern Europe and Scandinavia that it is actually there. So Lyme disease is super common. We see it where I teach in West Virginia, not uncommonly. 20-30% of the cases we have of unstable bradycardia are due to Lyme disease. So that's probably number one in the younger population. Number two would be a very rare heart attack affecting the AV conduction, atrioventricular conduction in the young person. So those are two rare things there. A heart attack in somebody young and fit is super rare. There's usually a genetic family component there. Mom, dad, brother, sister had heart attacks when they were young, like 40s, 50s. And the other rare thing is usually with heart attacks, you don't see bradycardia as you're presenting unstable rhythm. It's usually VT or ventricular tachycardia or ventricular fibrillation. So those are two. And then the last thing that we would see is much more acute, and it's in a patient that is actually experiencing severe hypoxic respiratory failure, does not have an airway, is not connected to a ventilator, and as you're trying to manage them, their sats are dropping like 70s and 60s% as oxygen saturation, not like 92, 88, but like 70s and 60s, and then their heart rate gets slow, and then if you don't get them managed, they're going to go into PEA arrest. So those are the one case for for EMS and society in general, and then 3 cases for younger military age population, of which Lyme disease is going to be your number one.
Overdoses?
Sure. Yeah. Narcotic overdose. Didn't even think about that. Narcotic overdose.
Got one. All right.
That's a good one. Yeah. Good job.
Awesome. So
narcotics, benzodiazepines, pretty rare, but you're going to see it with like a heroin overdose. You're not going to see it with a meth overdose.
Right. So, or the kid gets into grandma's pills kind of thing, calcium channel blockers, etc.
That's true too. Overdoses. I guess I didn't read enough for this podcast. In the general population. Second to aging conducting system would be overdoses, either clinical, where their physician just overprescribes an AV nodal blocking agent. So that's going to be, you're right, calcium channel blocker or a beta blocker, or an overdose that's either willful. The kid gets into grandma's pills. Somebody decides that's going to be their drug of choice for the suicide attempt, or unintentional. Somebody just doesn't understand how to manage their medications. Maybe they're a little bit older, maybe they have some cognitive issues, and they take too many. And so those are causes. Those are very difficult to treat. Like reversing a beta blocker overdose that's a for real ICU emergency.
Again, like we've come upon this person, we recognize that they have some kind of bradycardia. Their heart rate is, 30s, 20s. Okay. So like they're for real hurt. How do I go about kind of sifting through all these different causes to try and pick out like what is the treatment of choice for this one instance?
Well, hopefully you can get overdose off the table pretty quickly, either by pills around, illicit, drug paraphernalia around, bystander reports, and get that off the table pretty quickly. All right, is this a younger person or an older person?
Everybody's young at heart, but, 30s, 40s.
Okay, 30s, 40s, it's probably Lyme disease until proven otherwise, unless they're in an area that has no Lyme disease. So if you get overdose off the table, it's Lyme disease until proven otherwise. It's antibiotics for Lyme disease and whatever you need to support their rhythm to be perfusing. So mental status clears up, blood pressure stabilizes.
If I had to guess, you're going to stabilize them and then worry about putting antibiotics on board.
Correct. Yep.
So what are we going to do? I mean, is the stabilization of the patient essentially the same across the board?
Yes.
Okay. Let's go through it.
Yes. Alibi, however, except for hypoxic respiratory failure, in which the stabilization is you don't treat the heart, you don't treat the rhythm or the blood pressure, you treat the hypoxia.
Yep, and that's airway immediately.
That's airway and oxygen, or PEEP, but it's airway support, right? And I had one of those cases recently. I was helping some fellows do an intubation, and the patient had no reserve, and we'd mass ventilated them up to all we could get was like 90% with, PEEP valve of 15 and 100% FiO2 and aggressive masking. And I was actually doing the jaw lift to get to do the seal because he was so tenuous, and they tried and tanked his pressure and started getting bradycardic, and we just had to abort the attempt and mask him up again, and then we got the airway. So aside from that, stabilization is all the same.
Maybe that's another podcast, but so short of hypoxic causes,
correct.
Now we're going to some kind of chemicals. So at least, and I cheated. That's why I knew the answers anyway. The first recommended is atropine. So, I guess, was there a real reason that they pick atropine, or a thought process behind it?
It's usually handy. It's usually in pre-filled syringes in a lot of emergency setups, whether that's on an EMS rig or an emergency department or an ICU. It's fast, you don't have to mix a drip, or you don't have to mix a push of the other two, which I'll see if when we get to those. And it can be a little bit of a test to see whether they are going to respond to chemical chronotropy or rate control, rate improvement. But mostly it's just speed. When we have people that I know are coming in bradycardic, we'll just say, make sure you have the pacemaker at the bedside, pads at the bedside, and atropine at the bedside before the transport crew even brings them in. It's quick.
Okay. And that's, you're just giving 1 milligram bumps, and
correct.
It says the maximum you can give is 3.
Correct.
Okay.
Yeah.
I mean, I find often in, algorithms or, pre-hospital recommendations, guidelines, they say, okay, you stop here. But then as soon as I give them to somebody like you just can keep going. So it seems like, well,
paradoxically, it can actually cause a block. So that's one of the reasons on the dose limitation. And so usually with the other thing with atropine is because it's quick and available, it buys you time to set up something that's more long term. Whether that's chemical or electrical.
So that happens to be next on the list, right? So it says, transcutaneous pacing, which is always fun. Or you can do like a dopamine or epi drip. So
correct. Yep.
At least here in the States, I've always been told like go to electricity as fast as you can. Versus maybe in some of the classes I've attended from Europe, they're saying, hey, go to like epi or dopamine. Is there any real reason?
I honestly would go if my option for electricity is transvenous pacing, then I would, probably go to that because it's more long term and you basically and it gives you something every day that you can assess. You can turn down the pacemaker and see what their underlying rhythm is. So basically with all of the unstable arrhythmias, one of the things you're looking for is if there's no, obviously reversible cause, then is this a condition that's going to require a permanent pacemaker, right? Or a pacemaker defibrillator. And so if you have a pacemaker in, you can turn it down and in a second see what their underlying rhythm is. Are they still in the 20s? Are they still in the full block? Or are they not? And so you make that, decision of which is both, cost and morbidity of do they need a pacemaker. With a drip, it's a little harder, right? You turn it off and it takes a little while for their underlying rhythm to present because you've got to metabolize all the chemical out of their system. But but getting a transvenous pacemaker takes a minute. You got to call the can I put them in? 100%. Do I? No, because we have interventional cardiologists and we're teaching programs, so we call them. It's an hour. So what am I going to do to get them through the hour? The answer is either transcutaneously pace, which is painful, right? Because you're shocking somebody through the skin, and the skin has nerves. So it's painful. It has sensory nerves, so it's painful. The heart actually doesn't have sensory nerves. That's why transvenous pacing or permanent pacing doesn't hurt. Pain from a heart attack is actually inflammation from the ischemic heart muscle transmitted to nerves in the area around the heart, not in the heart itself, sensory nerves. The heart has plenty of autonomic nerves, but they're not sensory. So that's why a heart attack feels like sometimes radiating pain down the shoulder or to the back, because that's where those sensory nerves happen to be. So if you put a wire through a catheter or introducer catheter in the neck and feed it down to the right ventricle and pace through that, that's not going to hurt. But if you put a pad on them and start delivering shocks through the skin, we all know we have plenty of sensory nerves in the skin. That's why we can feel people touching us. That's going to hurt, and you're going to have to sedate them with something, And if you don't want to take their airway, your sedation options are limited. It's usually ketamine. Right.
At least in training, everybody says, you get to the point, I'm going to pace this guy, and it always says like, consider sedation. And everybody's like, it's been considered. We're going to do electricity. What is realistic? Because I've seen people, really, really not like what somebody's doing when they start pacing.
Mm-hmm. I would do a sedation dose of, my practice is I do a sedation dose of ketamine, so a mg per kilogram bolus, and then start a drip at, maybe a half mg per hour, per kilogram per hour. That's realistic for sedation, and they'll tolerate it. But we really don't like to transcutaneously pace for very long. That is a bridge to something. That is a bridge to a transvenous pacemaker. Now, I've kept people, and so because of all of that, I will try, and if I really need it, I'll try a dopamine drip next after the atropine rather than go to transcutaneous pacing. And transcutaneously pace basically only if they haven't responded to the atropine and they're really unstable, like their blood pressure is like 50s over 30s or 60s over 40s, and then try dopamine drip.
Okay, I guess why dopamine, not epi?
It seems to be a little bit more of a positive chronotrope. It seems to improve heart rate a little bit more reliably. But if I don't have it, epi is not bad, and I've used epi especially in code situations where I can get epi faster than dopamine. I can do a push dose. There's usually drips in the code cards. A lot of times in the military, that's all you're going to have. So it's certainly worth a trial, and it does work. I used it. I think when another unstable airway where they were. They were hypoxic, but they were also really unstable, like hypotensive and getting bradycardic. We pushed epi rather than phenylephrine because of its chronotropic effect.
So you're picking dopamine because it's more targeting the rate versus epi hitting rate and contractility?
Correct. I don't really care about contractility. I care about contractility, but I'm more concerned about rate. If somebody's got a low rate and a bad heart, like an ejection fraction of like 15%, get some problems.
I can only handle one at a time, right?
Then I would probably do epi if I knew that. If I had an ultrasound probe on and I knew that, then I'd probably do epi. But again, that's a really rare case, and in the military population, that's vanishingly rare.
I guess, how do you control your dopamine?
I usually start at 5 mics per kilogram per minute. And I usually start at 5. More than that doesn't seem to help. More than that doesn't seem to help with the rate. And I just go right to 5. Some people would start at 2.5 and titrate up if they're not getting a response. Either is fine. And
what are you targeting?
I'm targeting a rate over, number one, I'm targeting symptom improvement. Right? Blood pressure improvement, to a mean arterial pressure of I'll say 60. Mean arterial pressure will be, perfection is the enemy of good enough. I don't have to give them a mean arterial pressure of 80. I need to perfuse their brain, basically, and everything else. But, the brain is the most sensitive. 60 is fine. 65 is ideal. That's the textbook answer. And whatever rate does that, Typically with dopamine, you see somebody go from a rate in the 20s, 30s to like 60s, 70s pretty quickly. If it's going to work, it's going to be pretty quick.
And then obviously epi, generally same target range.
Same target range. The other nice thing about epi is we can get it in push doses quicker. So again, in that emergency situation, if you've run through your atropine and you're still mixing a drip, or you're waiting for the cardiologist, or you're trying to set up sedation so you can transcutaneously pace, you can have a stick of epi and give like 10 micrograms at a time.
Now, let's say we happen to find, random pills. So we start thinking some kind of overdose, could be a beta blocker, could be a calcium channel blocker. I guess, how would your treatment change?
You have to start treating the overdose or the heart's not going to respond, because now you've got competing chemicals causing your bradycardia, right? You either have opiates, which are way easier to treat than nodal agents, calcium channel blockers or beta blockers, because they're short on, short off. They metabolize really quickly. So you can give Narcan, set up a Narcan drip, and and pace them out of it, transcutaneously pace them out of it, and then they'll probably be fine in an hour. The other two are depending on the dosing, because sometimes you have these blood pressure medications that are given once daily, so that's super convenient. Oh, I only have to take my blood pressure pill once a day. I'll forget less. Well, the so what of that is you've bought yourself a half-life that is 24 times longer than a heroin overdose, right? At a minimum, right? And the pharmacist will tell you that drug's not out of your system until 4 half-lives are passed. So if you've got, long-acting metoprolol, which is beta blocker, metoprolol XL, long-acting once a day, you're talking like 96 hours until that's out of your system. Now, your heart rate's probably going to recover, somewhere around 2 half-lives, but that's still 2 days, right? And their chemical treatment is going to be really difficult because you are competing with a chemical that's blocking the AV node. And so the most effective way to get their rate up is going to be electricity. And then you're going to have to treat the overdose, right? Which is, glucagon or high intensity insulin therapy. The high intensity insulin therapy is very, very labor intensive. You need a central line. You need like aggressive, electrolytes are all over the place because insulin drives electrolytes into the cells. So you go like hypo this and hypo that. It was sort of the hotness in management of these nodal blockades for a while, and then it's just got so labor intensive that most places just went back to glucagon. Glucagon is ridiculously expensive. We did treat somebody with a beta blocker toxicity recently, and we looked up the price of glucagon, and I couldn't remember. It wasn't like, it wasn't like antibody targeted chemotherapy expensive, but it wasn't cheap either. It was probably 4 figures, maybe, if I remember.
For sure.
So it's not something like you're going to carry in your aid bag, or you're going to. Maybe some EMS systems would have it on the truck. I don't know.
I guess what the hell is different about glucagon than icing?
It might be I honestly don't know. It might be one of those things that's really like cheap as dirt to make, and somebody realized, like the whole EpiPen scandal, somebody recognized like people absolutely need this in an emergency, so we can charge 10,000 times its manufacturing cost. I don't know.
Nice. I have to find out who makes glucagon.
To buy their stock, right?
The side advantage of talking to you, Doug. So something like atropine, like you wouldn't expect that to work?
Not very well.
So you give them you just go, 1 milligram at a time, bump, bump, bump. You see no improvement. You have, suspicion that it's some kind of overdose, because at this point you're not going to really, really know.
Yeah. I'm going to go to pacing as soon as I can.
Go to pacing as soon as you can and scoop up whatever evidence you have and bring it to you.
Yeah. And if I have to transcutaneously pace without sedation, so be it. So be it. Because, like I said, if you've got something competing, a chemical is competing with you, and if it's narcotic overdose, or if it's a short-acting drug of abuse overdose, then, transcutaneously pacing and providing the antidote is generally going to work.
Imagine pacing somebody will help with their mental status, bring them back.
Mm-hmm. Yeah.
Yeah, I don't know. Is there anything else about bradycardia that we need to talk about but haven't?
I don't think so. We touched on Lyme disease a little bit. I definitely, and you said, let's get them stabilized first and then do the antibiotic, but definitely treat. We have had cases where it's almost at the point in West Virginia where, unless you're living in a retirement community, if you come in from home with complete heart block that's symptomatic, you're going to get, treatment for Lyme as while we test for it, because the test takes like 3 days to come back. So so we're going to treat you for it, because if it is positive, you're 3 days closer to resolution of the heart block.
Do you bother looking for the tick bites?
You can look for the tick bites. A lot of times you don't find it, they don't remember it, and it can happen weeks after, right? Lyme carditis can present weeks after, and so that's one of the reasons that you may not see evidence of a tick bite, rash or bite or whatever. I don't think I ever remember. Maybe one patient out of the dozen or so we've treated that have had Lyme carditis have actually remembered getting bit and pulled a tick off of them. So, the recommended antibiotic is ceftriaxone. With that severe Lyme carditis, we recommend IV antibiotics. Ceftriaxone is a drug of choice until the heart block resolves and their QRS complex is less than 300 milliseconds. Once that happens, and usually if they have it, they're going to respond in like 5 days. I think 3 days is the fastest I've seen. 7 is the slowest. So, average like 5 days of IV in an ICU or monitored setting. Then you can switch them to doxycycline 100 twice a day to complete a 14 to 21 day course. If all you have is doxycycline and you're in the field, start them on doxycycline.
Sure. I know you're saying, where you're working, essentially they're coming from being outside. You start them on antibiotics, and it's kind of I hope this works kind of thing while we're doing all the other stuff. How would you recognize that this is a carditis?
It's risk of exposure or actual exposure. And you've got to go back, like I said, you've got to go back weeks. Were you hiking? Were you working in the fields? Were you clearing bush? Were you mowing the yard? Did your dog have them? Did you pull them off your dog? All that type of stuff. Then you do the test. If the test is negative, they don't have it. So you can stop going down that route. Then it's something else. Usually at that point in our population, it's old, tired conducting system. Yeah. I'm not sure I remember where the question was going. How do I know it's carditis?
If Lyme carditis does it, then I would imagine any kind of carditis could do it as well.
Yeah, but you're getting like the myocarditis and the pericarditis. Those are very, very rare diseases. And that's a cardiac MRI to diagnose those.
Ooh, okay. I don't have one.
No. No.
Like ultrasound or nothing? You're not going to see any weirdness?
You would see heart failure generally with a myocarditis and the pericarditis, which you would not with Lyme. Lyme, you could see some heart failure with it, but it's more common that you see the block and relatively preserve heart function.
All right. So send the antibiotics.
The antibiotics.
Well, awesome. Is there anything else we need to chat about?
I think we covered we covered an interesting rhythm completely, or as completely as we can think of.
And if we forget something, we'll do it again.
If we forget something, it'll show up in the show comments, and then we can revisit it. We can have a rebuttal episode.
Well, awesome, Doug. Hey, I really appreciate you jumping on.
No worries. Thanks, and have a good rest of your day. And I'll probably see you soon.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast. Out.